video is a continuation of my previous video in which we had learned about the pathophysiology and the factors that determine chest pain, the classification of anti-anginal agents, and in details about the use of nitrates in the management of angina. In this presentation, we will be talking about the use of beta blockers and calcium channel blockers in the management of angina or chest pain. So in general, what are the factors that cause chest pain? Chest pain is caused due to increased myocardial oxygen demand, which is due to increased heart rate, increased contractility, increased preload and increased afterload. So increased myocardial oxygen demand increases the workload on the heart, thus increasing the oxygen consumption, and this causes chest pain. Also, decreased myocardial oxygen supply to the heart because of an atherosclerotic stenosis or vasospasm of the blood vessel, and this decreases the blood supply to the heart and the oxygen to the heart, causing chest pain. Thus, the therapeutic goal is to reduce the myocardial oxygen demand or to increase the myocardial oxygen supply, and this helps in the management of angina. So, the various types of angina are stable angina, unstable angina, and variant angina. So, how are the beta blockers useful in chest pain? As we know that stimulation of sympathoadrenal system increases the release of epinephrine and norepinephrine into the circulation, which acts on beta-1 receptors of the heart, increasing the heart rate and the contractility, thus increasing the workload on the heart and increasing the myocardial oxygen demand. Administration of beta blockers would antagonize the beta-1 receptors of the heart, and this prevents the action of epinephrine and norepinephrine, thus decreasing the heart rate, contractility, the myocardial oxygen workload, and decreasing the myocardial oxygen demand on the heart. Secondly, beta blockers, by increasing the diastolic filling period, increases the relaxation of the ventricle, the filling time of the ventricle, the relaxation of the ventricle, and this favors the blood flow to the subendocardial regions of the heart, which is more prone to ischemic injury. So beta blockers act by decreasing the myocardial oxygen demand and also increasing the myocardial oxygen supply, and this relieves chest pain or angina. So what are the other benefits of beta blockers? Beta blockers, in addition to relieving chest pain, also increase the exercise tolerance, thus reducing the incidence of chest pain during physical exercise or during exertion. Beta blockers also reduce the incidence of silent myocardial infarction in patients with coronary artery disease. Lastly, beta blockers also reduce the mortality and morbidity in patients with coronary artery disease. Speaking of the uses of beta blockers, as per the current guidelines in patients with stable angina, beta blockers are used as initial therapy unless contraindicated. However, in patients with unstable angina, these drugs are preferred, particularly in patients with tachycardia and hypertension or with ongoing chest pain. When it comes to variant angina, can beta blockers be used? The answer is beta blockers are contraindicated in variant angina. The reason being, in variant angina, there is segmental or diffuse vasospasm of the blood vessels or the coronary blood vessels, thus decreasing the blood supply to the heart. As we know that the vascular smooth muscle expresses the beta-2 adrenergic receptors and alpha-1 receptors. Stimulation of beta-2 adrenergic receptors causes vasodilatation, and stimulation of alpha-1 receptor causes vasoconstriction. So by giving beta blockers, we antagonize the beta-2 receptor effect. So beta-2 receptor mediated effect is blocked. Alpha-1 receptor effect gets predominant. So unopposed stimulation of alpha-1 receptors causes vasoconstriction, and this further reduces the blood supply to the heart in patients with variant angina, where the blood vessels are already constricted and the blood supply to the heart is already compromised. and this can aggravate chest pain, and therefore beta blockers, particularly the non-selective beta blockers, are avoided in patients with variant angina. So which anti-anginal agent would you select in variant angina? The anti-anginal agent of choice in variant angina is a calcium channel blocker. This is because the calcium channel blockers, by decreasing the calcium influx, causes vasodilatation, thus increasing the blood flow to the heart and relieving chest pain. Thus, in variant angina, beta blockers, particularly the non-selective beta blockers producing action on the beta-2 receptors, are avoided, and calcium channel blockers are the drugs of choice. Coming to the use of beta blockers in peripheral vascular diseases such as Raynaud's disease and frostbite. In these clinical conditions, the patient experiences ischemic pain because of reduced blood supply to the tissues. Thus, beta blockers, particularly the non-selective beta blockers, by blocking the beta-2 receptors, causes vasoconstriction, further reducing the blood supply to these regions. So, beta blockers are also avoided in peripheral vascular diseases such as frostbite, Raynaud's disease. Next, the use of beta blockers in bronchial asthma. The bronchial smooth muscles express beta-2 adrenergic receptors, and stimulation of beta-2 adrenergic receptors causes bronchodilation and relief breathlessness, shortness of breath, cough, and provides relief to the patient with bronchial asthma. So, beta blockers, particularly the non-selective beta blockers, by antagonizing the beta-2 receptors, can precipitate acute bronchospasm. So, this can cause worsening of bronchial asthma, and therefore non-selective beta blockers are avoided in bronchial asthma. Thus, non-selective beta blockers are avoided in peripheral vascular diseases and bronchial asthma, and cardioselective beta blockers are preferred because they have relatively little effect on beta-2 receptors. They have predominant effect on the beta-1 receptors of the heart, and therefore cardioselective beta blockers such as atenolol, metoprolol are preferred over non-selective beta blockers such as propranolol in the management of angina and also in conditions such as peripheral vascular disease and bronchial asthma. Next, can beta blockers be used in angina with heart failure? Now, beta blockers, as they decrease the heart rate contractility, are avoided in patients with decompensated heart failure. So, beta blockers can only be used in patients with stable heart failure. When used in patients with heart failure, they have to be initiated at a low dose and titrated upwards gradually and monitored for efficacy and safety. So next, what are the side effects of beta blockers? Beta blockers have been reported to cause fatigue, insomnia, impotence in some patients. So can beta blockers be combined with other anti-anginal agents? Beta blockers can be combined with nitrates, and this produces additive effect or synergistic effect. Beta blockers and nitrates, by acting through different mechanisms, produce better efficacy and better relief of symptoms of angina. In terms of safety, the undesirable effect produced by nitrates, which is known to induce tachycardia because of the hemodynamic effects of nitrates, and this is offset by the use of beta blockers that is known to reduce heart rate. So, beta blockers, by reducing the heart rate or heart rate lowering property of beta blockers, helps to counterbalance the undesirable effect of nitrates, making it safer for use. So, beta blockers when combined with nitrates produces better efficacy and safety and may be used in the management of angina. Beta blockers can also be used with calcium channel blockers, and when used together, they act through different mechanisms and they help to relieve chest pain and produce better efficacy. But to be kept in mind that beta blockers have a heart rate lowering property, and calcium channel blockers, by inhibiting calcium influx, also lowers the heart rate. So both beta blockers and calcium channel blockers, by acting together, further lower the heart rate, and this can increase the chances of bradyarrhythmias in patients when used together. Next, we move on to the use of calcium channel blockers in the management of angina. So, how are the calcium channel blockers useful in the treatment of chest pain? The calcium channel blockers inhibit calcium entry through the calcium channels that are expressed in the heart and blood vessels, including the coronary blood vessels and peripheral arteries. By inhibiting intracellular calcium influx in the heart, they reduce the contractility and the heart rate, thus reducing the myocardial oxygen demand and decreasing the workload on the heart. By inhibiting the calcium channels in the coronary blood vessels, they cause vasodilatation, dilatation of the epicardial coronary blood vessels, increasing the blood flow to the heart, and by decreasing the resistance in the peripheral blood vessels, they decrease the afterload on the heart, thus decreasing the myocardial oxygen demand. So, calcium channel blockers help to relieve chest pain by decreasing the myocardial oxygen demand and also increasing the myocardial oxygen supply to the heart by causing vasodilatation and increasing the blood flow to the heart. The calcium channel blockers are categorized into two groups, the dihydropyridine group and the non-dihydropyridine group. The dihydropyridine group includes nifedipine as a prototypic drug, and the other drugs that are included in this category are amlodipine, benidipine, nicardipine. The non-dihydropyridine group includes verapamil and diltiazem. The drugs that are included in the dihydropyridine group have vasoselective action with no action on the heart. So since they have profound action on the blood vessels, they cause dilatation of the epicardial coronary blood vessels, increasing the blood flow, and also decrease the peripheral vascular resistance, decrease the afterload and the workload on the heart, and help in relieving chest pain. The nifedipine, which is the prototype drug, has a rapid onset of action and causes a sudden fall in blood pressure. Due to sudden fall in blood pressure, the sympathetic baroreceptor reflexes become activated, and this causes tachycardia as a side effect. So tachycardia is a side effect and a drawback of nifedipine, and this drawback is overcome by other drugs such as amlodipine, nicardipine. Amlodipine has a long half-life and a steady plasma level, and therefore sudden fall in blood pressure is avoided and tachycardia does not occur with amlodipine. So amlodipine is a safer drug compared to nifedipine, and nicardipine has selective action on the coronary blood vessels, causes dilatation of the epicardial blood vessels, increasing the blood flow to the heart. Therefore, amlodipine, benidipine and nicardipine are preferred over nifedipine in the management of angina. So now let's compare the actions of nifedipine with verapamil or diltiazem, which belongs to the non-dihydropyridine group of drugs. So if we compare the actions of nifedipine and verapamil, which belongs to non-dihydropyridine group of drugs, nifedipine has profound and predominant action on the blood vessels with little or no action on the heart. So heart rate lowering property is absent with nifedipine, and tachycardia is seen as a side effect, as a drawback of nifedipine. Verapamil on the other hand has predominant action on the heart. It has cardiac depressant property, it has heart rate lowering property, and it also has minimal action on the blood vessels, decreasing the peripheral vascular resistance, decreasing the workload on the heart, and the tachycardia that is caused by verapamil is counterbalanced by its heart rate lowering property. So tachycardia or increased heart rate is not seen with the use of verapamil, whereas tachycardia is a common drawback, common side effect of nifedipine. Also, it is to be noted that verapamil, because of its cardiodepressant property, should be avoided in patients with angina and heart failure. However, these are preferred drugs in the management of supraventricular arrhythmia, as they reduce the SC nodal automaticity, reduce the conduction through the AV node. So they are very helpful in the management of supraventricular arrhythmias such as atrial fibrillation, atrial flutter, and they help to control the ventricular rate in these clinical conditions. So to sum up, calcium channel blockers are very effective drugs in the treatment of vasospastic angina, as they are known to dilate the stenotic blood vessels, increasing the coronary blood flow and also decreasing the peripheral vascular resistance and decreasing the workload on the heart. They are as effective as beta blockers in the treatment of stable angina and can also be used in the management of unstable angina. The preferred calcium channel blockers in the treatment of angina are amlodipine, benidipine and nicardipine, whereas verapamil and diltiazem are preferred drugs for the treatment of supraventricular arrhythmias, as they have cardiodepressant property, reduce the SA nodal activity and thus are helpful in treating or controlling the ventricular rate in supraventricular arrhythmias such as atrial fibrillation and atrial flutter. So with this we come to the end of the topic. To summarize, beta blockers are the drugs of choice for the treatment of stable angina but are contraindicated in variant angina. In calcium channel blockers, the dihydropyridine group of drugs such as amlodipine, benidipine and nicardipine are preferred drugs for the treatment of vasospastic angina and are equally effective in the treatment of stable and unstable angina. For more details, you can refer to my book, that is Case-Based Learning in Pharmacology, which is published by CBS Publishers and Distributors. These are my references. Thanks for watching. Please like, share and subscribe.